identified and could possibly reverse with optimal control of his diabetes and hypertension. So we try to share those examples that if you do reach out to the patients, if you remind them, you're not bothering them. Because there is often that mindset, I don't want to bother my patient. He's coming in for something completely else right now, that's out of his mind. A lot of our patients, and I hope most, actually appreciate that reminder that something else needs to be looked at. I'm going to shorten that, but it's a similar...
I'll wait. I have a whole list.
Okay, I'm going to try to wrap it up, that we have a few more minutes for questions and answers. This is a similar patient story. It's about like engaging health coaches to kind of like work with the patients. And it's basically a success story how the health coach worked with the patient and they kind of lowered the A1C within a 9-month span.
So for those of you who want those details, those slides will be in the next email you receive from us, and they'll be posted on our website, rightcare.berkeley.edu.
We come to our last couple slides. So again, to motivation, through recognition and celebrations, it's important for us that we, on the bottom right corner, you see like an outstanding service award. It's symbolic. It's like a piece of paper. It's a nice piece of paper, but it's a piece of paper. And we frame it, and the social medical directors at the Gemba Walk give it to the staff if they did a lot of work, if they really helped us to achieve our targets. So it's a form of recognition. We also celebrate. You see our medical director. He provided us with like a little Oscars. You can really see that, and a little crown for our medical director in Santa Cruz who did really well. So it's like bring in a little bit of fun in our work. One last thought to share with you, like a lot of our work is also about our culture, and a culture like of continuous improvement, and that we don't want to aim for perfection, like we just want to make the next step. Don't make it too complicated, and send the message that improvement is an important part of our work. So no matter where you are, even if you are in the bottom 10% of our performers right now, don't look where you need to be at the top. Like if you can improve by 10%, we're already happy. So we just encourage everybody, just do the next step. Don't get overwhelmed by, this is like, we're such a huge gap, we're too far behind anyway.
So why don't you read that last quote?
Changing our mindset?
Yeah, Theta Care was at our summit. They're one of the top performers in the nation. And their quote is?
Improvement isn't an interruption to the work, improvement is the work. That was from the Theta Care nurse. Just to mention that motivation it's not just about our care teams, it's about also our patients. So we need to motivate and engage our patients, and we have different people in place and continuously from different directions kind of encourage our patients to get those important screenings done. Final thoughts. So for today, for you, I was thinking, what are best practice ideas for you to consider? I'm fully aware that we're like a big organization, we might have resources you don't have. But I do think a few takeaways: visibility of targets, your current performance and your gaps. You can do that in a simple Excel file. You don't need a sophisticated system. You might help with getting the data, but once you have the data, make it visible. Make it actionable. If you do show them how they do, show them the patients that need to be reached out to. Have a broad support team, the broader the better. I continuously try to put the load on different people, like for example for us, including endocrinology into patient outreach. This continuous engagement piece, it's not a one-time thing. You need people in place who continuously champion this kind of work. Celebrate success and recognize the contribution of individuals. Give them a pat on the shoulder. We all like that. And engage your patients to communicate that you want to be a proactive partner. I kind of like emphasize that in our care teams, say that patients are not really happy about all those calls they're getting. And I tell them, try to explain that we want to be this proactive partner with them to remind them about important screenings for their health. Thank you. Any questions? Oh, you have a whole lot of questions.
So maybe let's see if any of the medical directors, thank you, Terry, it's good to see you.
Thanks, Hattie.
See if any of the medical directors have questions first, and then we'll go back to somebody who's already spoken.
I don't know if I qualify as a medical director.
Of the County of Sacramento, Dr. Olivia Casirier.
But I did want to go back to the point that you made, Hattie, about the difference between looking at the risks individually as opposed to getting all of the patients at the end when you're supposed to do the reporting. I think this goes back to the million heart, doing it all at once. I think both of them are important. Doing it individually is important because that's when you get the opportunity to do education to a patient. But looking overall is also important, going back to what Stefan was talking about, looking for where the gaps are, what kind of groups were missed, and being able to look at the root causes. So both answers are correct. You need to do both.
I have one comment that actually, from my experience, we had a similar discussion around meaningful use, and we mapped out the process, how we can document meaningful use. And my first thought was, if we asked our care teams to do this manually every time, almost nobody will do that. If they have to go to a separate system, even within the system, if it's multiple steps, you very quickly lose them. So I would be, just like my personal opinion too, I also like the approach, like if we can catch more, and with a more overarching data transfer, that's really helpful.
So I have a few comments. Can you
Dr. Gil Simon from River City.
Right. So I'm a medical director of a Medi-Cal-only organization. And as you know, Medi-Cal will soon take care of 12 million Californians, a third of every Californian. That number is more than all but 3 states' populations, so it's a huge number. And as far as I know, every Medi-Cal provider is not part of an integrated, comprehensive system. We all function as independent provider groups. Some are very large, some are very small, most are very small. About half are FQHCs, and they're all independent, not part of the system. So this is a great approach for the comprehensive, very large, highly motivated, highly resourced organization. But what's going to happen with the Medi-Cal population? There's going to be 12 million of them, and there's no way to apply most of the tools that you've applied to your population. Do you have any suggestions as to how any of this can be adapted to the tens of thousands of Medi-Cal providers scattered throughout the states functioning as independent individuals?
So Gil, I just want to say that what we do see in the data is exactly what you said, and it's what I talk with people about all the time. We know that the solo and small group practices is where real help is needed. Cracking that code is part of why Sutter IPA and Hill Physicians are partnering with their independent practitioners to try to give them practical tools like this wonderful pocket card. They do tend to disappear. They're like candy to physicians. Notice if you set a pocket card around them, they grab them. But one thing that we might want to do is try to connect them with more resources in the community, like community pharmacists on the care team. So I'm glad you said that while Dr. Betsy Thompson's here, because she can help us figure out how to crack that code for the solo and small group practices. And Stefan, give it back to you.
Well, the first thought I had too was like, if I would focus on that, my first question would be like, can we determine in any way how we're currently performing? Like, do we have a patient list? Like that's where I would start. You know, do we have a patient list of all the patients that are in that patient population we're trying to reach? And then, do we have a current status? Do we know, have we reached out to them already? And I'm thinking really simplistic. It can be like a really simple file, but I would have difficulties to do something in a systematic way if I don't know who is in that group and have they already been outreached or not.
It's an uncountable group, and many of them are elderly and never got involved with the electronic medical record system, which is complex. And unfortunately, that group takes care of about half of all the Medi-Cal insured population in California.
I can tell for us, like, I mean, we have the advantage of like having more resources, but the medical patients are included in our reporting. So, and a lot of those patients, same situation, are older, or very old age. But again, like, I would always try to go back, you need to be able to identify all the patients that you need to reach and have some kind of status. Have they been reached out to or not? Otherwise, it's very, how do you want to do that?
Dr. Simon, I'm Cindy Hopper, and I'm with Sutter. And Dr. Simon, hi. I'm Cindy Hockard, and I'm with Sutter, and I'm not Sutter, Sutherland. Sorry, Dr. Revela. Although, you know, you can get my resume, we'll see. But anyway, I'm working with a group of FQHCs with Bobby Gliatout from Halo and Chuck Wyson from Health for All. And we are cracking that nut by collaborating with a tool that allows you to get that information and then share it with the primary care physicians in a community-based care coordination record, and then working with our payers to put in fee-for-service, pay-for-performance types of contracts so that the incentives that have been discussed earlier are in place for those FQHCs as well. So it's very new in Sacramento, but we think that it's a real opportunity to close some of those gaps that those independent FQHCs are facing. So I'd be happy to follow up.
Thank you. So Dr. Betsy Thompson had something she wanted to ask.
Well, I think actually, Gail, the FQHCs, I think, are in a better situation than your small practices. And, you know, you all, maybe not yours, but you've done some neat work, have been doing things along the lines of what she's suggesting with registries since at least the early 90s with chronic care, trying to work around chronic care collaborative, including diabetes and other conditions. So I did want to remind you all, though, I think that is exactly why the federal government and Congress decided to put almost $30 billion into electronic health records, is because without the data, I mean, how do you know where you are? We're not going to solve the problem of doctors who are maybe close to retirement, never going to get on board with EMRs or with data. But that really has made tremendous progress in getting people onto electronic medical records. The next step, though, it isn't having an EMR in every office, it's using it for exactly the sort of thing that he's shown here, that CMS is now starting to pay for. It's, like I say, it's not just having it, it's using it to improve care. So I think, I mean, I'm really hopeful. I think we're going to see a lot of innovations, a lot of ways to practice now over the next 5 years. And you may lead the way.
Yeah.
So, and remember, I want to remind everybody to do their CME form in the back.
And thanks to HSAG for providing the free continuing medical education. It's a lot of work for them, so it helps us if you can fill that out. And Stefan, if you wouldn't mind staying to answer questions, we can continue this conversation among anybody who wants to continue.
Thank you, Stefan. That's a great presentation. Dr. Thompson, thank you again. And hopefully we'll see you next month. And please fill out your evaluations, especially TFT.
So August 10th, we will have outpatient intensive care. See you then.
Yeah, I just met with Bobby.